Well, it's very nice to be here this afternoon. Thank you for the opportunity to educate you and provide you some additional resources as you navigate this chronic illness that you unfortunately have. I'd like to make this informal today, so if you have any questions or something comes up as I'm presenting, feel free to just raise your hand and interject. I'd like to make this as informative as possible, and I'd like everybody to understand the information that I'm presenting here today. I am a member of the Heart Group of Lancaster General Health, and my specialty is advanced heart failure, pulmonary hypertension, and mechanical circulatory support. Okay. So today, the overview of my presentation is there on the screen. We're going to be reviewing basic cardiac physiology, talking a little bit more about the definition of pulmonary hypertension. We're going to talk about some different types or different ways that pulmonary hypertension is classified. I'll talk specifically about how pulmonary hypertension affects the folks in this room that have scleroderma. We'll then start talking about signs and symptoms, go through an evaluation, discuss treatment options, and then of course at the end, if there are any questions, I'd be happy to answer those. So we'll start by reviewing some basic cardiac physiology. See if I have, we'll try to use this pointer here that I have on the computer. So here on your left is a picture of the heart as it would look on the outside of the body. And on your right is more of a cross-section of the heart. So blood in our body comes through these veins. We have veins that drain our legs, and then veins that drain the brain and the top part of our body. All of that deoxygenated blood that comes from the veins actually enters the right side of the heart. And it goes into the right atrium, which is there on the top, and then down into the right ventricle. The right ventricle is the main pumping chamber on the right side of the heart. From the right ventricle then, the blood travels to the lungs, where it picks up oxygen. It then returns through these pulmonary veins to the left side of the heart and goes into the left top chamber, the left atrium, and then down into the left ventricle, which is the main pumping chamber for the left side of the heart. And the left ventricle then is responsible for pumping blood out into the aorta, which is the main blood vessel. That blood vessel leaves the heart and supplies blood vessels again that go up to the brain and then also down to the legs. So basically we have deoxygenated blood coming into the right side of the heart, going to the lungs to pick up oxygen, and then coming back into the left side of the heart, where it's then circulated out to the rest of the body. On your left there, you see a picture of a normal heart. Sorry. Actually, do you have the laser pointer that Dr. Amanula was using? Oh, right here it is. Maybe we'll try this instead. So on the left here is a normal heart. Again, you see the right side of the heart here and the left side of the heart here. In patients that have pulmonary hypertension, you notice that the right side of the heart is enlarged. And this is because of elevated blood pressures out in the pulmonary vascular bed. So the elevated pressures there in the lungs, in the blood vessels of the lungs, actually transmits back to the right side of the heart. And because there's elevated pressure on the right side of the heart, it can cause the right side of the heart to become thicker than it should be and also to become larger than it should be. The pressures in the right side of the heart are higher than they should be, and that's what we as heart doctors worry about. So the true definition of pulmonary hypertension is a form of high blood pressure that specifically affects the right side of the heart, and it comes from high pressure within the blood vessels in the lungs. We're able to actually measure the pressure in the pulmonary artery, and so a pressure greater than 25 millimeters of mercury is what us pulmonary hypertension physicians become concerned by. There's also another pressure called the mean pulmonary artery pressure, and if this becomes greater than 40 as a patient is exercising, that's also concerning. Sometimes high pressures can be normal. So about 5% of the population over the age of 50 will have mildly elevated pressures. Overweight patients and athletes can also have mildly elevated pressure. We'll talk a little bit later in the presentation about how these pressures are actually measured. This is a little cartoon of the changes that actually happen in the pulmonary vessels. You can see on the far right, on the far left of the screen, we have a normal blood vessel within the lung. Each blood vessel has 3 layers to it. We call those the adventitia, the media, and then the innermost layer is called the intima. As pulmonary hypertension progresses, you begin to see changes in the blood vessels themselves. So where this middle layer, the smooth muscle layer, becomes thicker than it should be, and the intima, which is that innermost layer, also becomes thicker and inflamed. On the far right is an example of very severe damage where you actually can get little blood clots that form and other sorts of problems within the actual lumen of the vessel itself. At the very top, you can see risk factors for pulmonary hypertension, things such as collagen vascular disease, patients that have what we call congenital heart disease, that's heart disease that you're born with. Also, patients with HIV infection are at risk for pulmonary hypertension. Certain drugs, a couple years ago, there was a diet drug called fen-phen that now is very classically associated with pulmonary hypertension. So when we talk to our patients in the office, there are certain medicines we might ask if patients have ever taken. And then unfortunately, rarely we see pulmonary hypertension associated with pregnancy, but that can be fatal for both the mom and the infant. So the previous slide was kind of more of a cartoon demonstration of what happens to the blood vessel. This is what we actually see in the pathology lab. Again, on my right is a normal blood vessel, and then on my left is a blood vessel in a patient that had pulmonary hypertension. You can see the difference there, again, with the thickening of the different layers. And also, if we had a pathologist here, they would talk to us about how the cells looked angry and inflamed. So we also see that on the left as well. So you might ask me what causes this inflammation, and we believe that there's 3 specific pathways that are involved. You can see those pathways listed there on the slide. One is the endothelin pathway, the other is the nitric oxide pathway, and then the prostacyclin pathway. In a normal patient, in a patient that does not have pulmonary hypertension, these normally occurring substances would lead to good things, dilation of the blood vessels, low pressures in the lungs. But in patients with pulmonary hypertension, some of these good hormones or substances are missing. And so the result becomes elevated pressures within the lungs and inflammation. Towards the end of the presentation, you'll actually see the slide again, where we'll talk about some medicines that actually target these pathways and help prevent some of the long-term damage that we can see to the blood vessels in patients that have pulmonary hypertension. This is the classic Dana point classification of pulmonary hypertension. It's called Dana point because that is the location where a bunch of researchers and clinicians met and actually developed this classification a number of years ago. You'll see that there are 5 main types of pulmonary hypertension. The first class there is classic pulmonary hypertension, which is also referred to as pulmonary arterial hypertension, or PAH for short. And under that, under segment 1.4.1 is connective tissue disease. So scleroderma is considered a connective tissue disease. Patients that have scleroderma and pulmonary hypertension have pulmonary arterial hypertension. However, as I mentioned a couple of slides ago, there's also other causes for pulmonary hypertension, pulmonary veno-occlusive disease, pulmonary hypertension due to left heart disease. That means there's something wrong with the left pumping chamber of the heart. And those pressures can also back up to the right side of the heart and cause elevated pressures within the lungs. Patients, Dr. Amanullah sees a lot of patients that have lung disease. So if you have pulmonary hypertension from pure lung disease, that would be class 3 pulmonary hypertension. Class 4 pulmonary hypertension is patients that have chronic blood clots in the lungs. That can also elevate the pressures in the lungs over time and lead to damage of the right side of the heart. And then there's always, in medicine, there's always a class for we're not quite sure. So that is pulmonary hypertension class 5, where we're not quite sure of the mechanism, or maybe there's a couple of different things going on leading to the pulmonary hypertension. Any patient with pulmonary hypertension, we also like to classify by how functional they are. We also do this for our patients that have chronic heart failure. So patients that have very little functional limitation, patients that can do kind of whatever they would like without any shortness of breath or fatigue, those patients are in class 1. On the contrary, patients with class 4 cannot carry out any physical activity without having symptoms and really are actually symptomatic just sitting at rest. We do think that there is some association between these functional classes and the degree of problems with the right side of the heart. So usually our patients that have class 4 symptoms, when we look at ultrasounds of their heart, you can see that the right side of the heart is very damaged, not pumping well. The walls of the right side of the heart might be thicker than they should be. Whereas the patients that are in class 1 that feel well and are doing well, usually the right side of their heart is working better and doesn't have evidence for damage. So let's talk a little bit about pulmonary hypertension and scleroderma. When I showed you the classification, we talked about pulmonary arterial hypertension and its association with connective tissue disease. Scleroderma is actually the most common connective tissue disease associated with pulmonary hypertension. There are other connective tissue diseases. We were talking about some of those earlier today, lupus. Those can also be associated with pulmonary hypertension, but scleroderma is most common. It's actually more common in patients with limited scleroderma as compared to systemic scleroderma. Patients with scleroderma have about a 1 to 2% risk per year for developing pulmonary hypertension. And when we look at all of the patients across the world that have pulmonary hypertension, about 8 to 15% of patients with scleroderma will have pulmonary hypertension. There is a higher incidence if interstitial lung disease is present. That's kind of what Dr. Amanullah was talking about earlier. Unfortunately, it is the leading cause of death in scleroderma patients. So it is very important that we recognize this early and that we begin treatment early. And patients with pulmonary hypertension overall have a worse outcome compared to patients that might have lupus and associated pulmonary hypertension. So again, another reason why anyone with scleroderma should be evaluated for pulmonary hypertension, and we need to have regular routine follow-up to detect it in its early stages. So what does this mean for the patients here in this room? Well, you want to be aware of signs and symptoms for pulmonary hypertension. Dr. Amanullah did an excellent job earlier this afternoon talking about some of these symptoms, but most importantly, trying to explain that there's a lot of different reasons why patients can be short of breath or feel fatigued. And lung disease from scleroderma and also pulmonary hypertension from scleroderma might just be one of the reasons why patients are feeling short of breath or fatigued. There are also other reasons, such as anemia. That's a low blood count. So our blood is responsible for carrying oxygen to our muscles. So when we are walking up steps, we need a good blood count in order to get, oxygen to our thighs and oxygen to our arms so that we can walk up the steps. And if our blood count is low, those tissues aren't going to be getting the oxygen that they need, and that can make people feel short of breath. Dr. Amanullah also talked about lung disease from scleroderma, and that can certainly cause shortness of breath. And then the last thing is really a diagnosis of exclusion, but deconditioning. So I see, maybe 10 patients a day in my office that are short of breath. And one of my jobs is to figure out whether there is something significant going on and something that needs treated. But sometimes at the end of the day, after we've done a lot of testing and all of the testing turns out normal, I have to sit down and talk with my patient and say, I think you're short of breath because you're not moving enough. But that always is a diagnosis of exclusion. Patients with pulmonary hypertension can also feel fatigued, they can have chest pain, and they can also feel faint or actually pass out. We become very concerned when someone tells us that they have passed out as they're doing some sort of physical activity. That can be a very serious warning sign of very severe pulmonary hypertension. So the evaluation for pulmonary hypertension starts with an echocardiogram. That's also known as an ultrasound of the heart. It's non-invasive. Really, honestly, the worst part of it is the cold gel that they use. Although now I guess we have these fancy warmers where we can even warm up the gel. You might also feel just a little bit of pressure as the person who's performing the ultrasound sometimes needs to squeeze a little bit between your rib spaces to get the best picture of the heart. This is really the best way that we have to look at both the right side of the heart and the left side of the heart. We can actually make some pressure measurements when we are doing the ultrasound, and it really is the first step and gives us a lot of information about your heart. There's a lot of literature now suggesting that patients with scleroderma should have ultrasounds of their heart done on a yearly basis. Again, so that if we begin to notice any sort of change, we're detecting that very early and not 5 years down the road when there's already been significant damage done to the right side of the heart because of pressures that are too high. We also would do an ultrasound on someone who has a change in their symptoms. And so if you used to run around without any shortness of breath and now you can't even get out to the mailbox and back to the house without having trouble, then it certainly would be a time to do some testing. So this is what an ultrasound of the heart looks like. I'll give you a little orientation here. So this is the right side of the heart, and the heart is a little upside down in these pictures. So these are actually the top chambers here on the bottom, and the main pumping chambers then are here on the top. And so this is the right side of the heart, and then over here is the left side of the heart. And as you can see in this echocardiogram here, the right side of the heart is much larger than the left side of the heart. And if you could imagine, it's actually kind of squeezing the left side of the heart. So this is an abnormal echocardiogram, very concerning for pulmonary hypertension. This patient actually had treatment for their pulmonary hypertension. And on the other side of the screen here, you can see what their follow-up ultrasound looked like. This is actually a normal looking heart, where the right side of the heart is very small, almost kind of crescent shaped. The left side of the heart is a little bit larger and more oval shaped. Again, just another example of a patient that was diagnosed with pulmonary hypertension. On the right side was their pre-treatment echocardiogram, where the right side of the heart is enlarged. And on the left side of my left side of the screen there is their echocardiogram after treatment, where the right side of the heart has returned to normal. So I mentioned early in the presentation about elevated pressures in the heart chambers, and the fact that us doctors, we actually get numbers to tell us what's elevated and not, and what's normal. The echocardiogram can provide a lot of information about what the pressures in the heart about how elevated the pressures in the heart chambers are. But the real definitive way of measuring the pressure within the heart chamber is to do a procedure called a right heart catheterization. The cartoon on my left shows the actual process for a right heart catheterization. You can see up at the very top here, there's a little line going into this patient's neck. That's actually this line here on the left. This is what we call a pulmonary artery catheter, or a Swan-Ganz catheter. It's actually a very flimsy piece of plastic. It's about as big around as a spaghetti noodle. And what we do is we get access to the vein here on the right side of the neck. It's actually a direct shot then into the right side of the heart. So we like to go through the right side of the neck. That way we're not, that way we have a one shot into the heart. We don't have to worry about going out into the arm or anything like that. On the far side of the cartoon, you can actually see the catheter coming into the heart. We measure a pressure in the right atrium, that's the top chamber, make a pressure measurement in the right ventricle, and then we make a pressure measurement out in the pulmonary artery. That's the artery where the blood leaves the right side of the heart and then travels out to the lungs. So that sounds really scary, right? Yes. Well, it is actually not too scary. Patients go to a special area of the hospital for the procedure called the cath lab. Probably the worst part of the procedure is that the table is very cold and very hard. It's probably like laying on an ironing board. You get some medicine to make you very sleepy and relaxed. The doctor who does the procedure will actually numb the area where they're going in for the procedure. The pressure measurements are made, and then all of the equipment is removed. The patient gets a little Band-Aid on their neck, and then they kind of wake up from the sleepy medicine that they were given. The overall risk to doing the procedure is very, very low. There's a very small risk for bleeding. The risk for damage to the heart or damage to the lungs as the procedure is being performed is about 1 in 5,000 to 1 in 10,000. So again, it's a relatively safe procedure. Most patients have the procedure done at the hospital and go home the same day, unless we find that the pressures are critically elevated. And in that case, we might actually ask the patient to stay in the hospital with us so that we can start some medicine quickly and help to lower those pressures. Sometimes during a right heart catheterization, we give medicine to see if that has any effect on the pressures. Sometimes it's an inhaled medicine that we give, sometimes it's an IV medicine. And again, I had already mentioned if the finding is critical, then usually we ask the patient to remain in the hospital. Sometimes we actually leave that line in the neck for a day or two Again, it's not painful, just maybe a little uncomfortable because there's a lot of monitoring equipment that's also attached to that line, but not painful at all. Most insurance companies actually require for these pressures to be measured by a right heart catheterization before medicines can be started. So I told you that the ultrasound or the echocardiogram can give us a sense of how elevated the pressures are, but insurance companies actually like to see these exact numbers on paper before they give approval to start medicine. If we make pressure measurements and they're borderline elevated, about 30% of those patients will actually go on to develop pulmonary hypertension. So those are patients that we're going to be following very, very closely. Without a doubt, we'll be getting yearly ultrasounds on those patients and maybe even asking the patients to come back to the cath lab in the future to have the pressure measurements rechecked. There are other tests that also are done. Again, we wouldn't want to put blinders on and say, oh, you have scleroderma, the pressures in the right side of your heart are high, so it has to be from your scleroderma. Again, just the way that Dr. Amanula was talking earlier this afternoon, we also have to think outside the box and make sure that we're not missing other reasons for the pressures to be elevated. So we often check blood work. We're going to check the urine for protein. Sometimes we request a nuclear medicine scan of the lungs to look for chronic blood clots in the lungs. Sometimes we might order a CAT scan of the lungs, and then we often do a 6-minute walk test. That's more to gauge how functional, to gauge the functional status of the patient. That test we follow over time to make sure that patients are doing well on medicine and remaining as functional as possible. So there are some myths that I definitely want to make sure that everybody that walks out of this room today is no longer thinking these negative sort of thoughts. And that is, there's nothing that can be done if the pressures in my heart chambers are high, you know, there's nothing we can do. The other is that medications do not work. We know that the medications that we're prescribing are effective and help patients live longer lives with more quality. Medications are very expensive. Some of these medications that we've been using now are generic. And some of our patients we're sending to Costco where they're getting medicines like sildenafil or tadalafil for $40 for a month's supply. And that, again, as a physician who treats this condition, is a very exciting thing because now our patients can afford their medications. Clinical trials over time are becoming larger, and the information then is becoming applicable to more patients. And so it's also a very exciting time to be in this field because we have more research than ever to help our patients feel better. This was the slide that we saw at the very beginning, and I told you that we would kind of come back to this to talk about treatment. So most of the treatment options we have now are medicines that fall into the class of endothelin receptor antagonists, phosphodiesterase type 5 inhibitors. These were drugs that were initially created for pulmonary hypertension, drugs like sildenafil and tadalafil, that were also found to be beneficial for erectile dysfunction. And so some of these drugs have multiple purposes. We also use prostacyclin derivatives. Some of the medicines in this class are actually given in a subcutaneous or in a continuous IV infusion form, but recently we actually had a pill form come to market. And again, that's very exciting because some of our patients that used to have to carry infusion pumps around are now being transitioned to a pill instead. I told you that sometimes we give medicine in the cath lab to see if that lowers the pressure, and that's a medicine called nitric oxide. We give it in the inhaled form. Same type of thing if you went to the kind of in a similar class as inhaled medicine that's sometimes given for sedation purposes at dentist's office. But we give it in the cath lab to see if it lowers pressures in the heart chambers. So those are the kind of the 3 or 4 main classes of medicine that we have. There are some lifestyle considerations as well, things that we talk to our patients about in the office. We do recommend a sodium-restricted diet with close monitoring for fluid retention. So anybody with elevated pressure in the heart chambers, in the right side of the heart or the left side of the heart, you're at risk for holding on to extra fluid. And unfortunately, when we consume sodium, our body tells us then to hold on to extra fluid. We often give water pills or diuretics to help overcome that, but we would also always recommend that patients watch their sodium intake, because if they watch the sodium intake, the fluid level is likely to be lower, and that also helps to lower the pressures in the heart chambers. For that same reason, we recommend that patients weigh themselves daily. By stepping on the scale every day, we get a sense of whether you're retaining fluid or not. We know if patients gain 3 pounds overnight or 5 pounds in just a couple days, that is a fluid retention problem. So even if we totally changed our diet and we decided we were going to start eating out every night and eating steak and French fries and things like that, usually people don't gain more than about 1 pound or 2 a week. So that's more body weight or body fat gain. Patients with pulmonary hypertension sometimes need to avoid high altitude. Patients with pulmonary hypertension that need to fly, we have to do special tests to see if after they get in the air, whether their oxygen levels drop. So sometimes we have to recommend that patients fly with oxygen. I know that Dr. Amanula's office has been helpful with that sort of testing in the past, making sure that our patients are safe as they travel. Patients, for the most part, it is safe for patients to kind of go about their usual activities, take walks with their dog, and maybe spend time outside with their family. But if patients are having near fainting or fainting symptoms with activity, then those patients actually need to avoid exerting themselves. And of course, doctors always recommend that patients never smoke for any reason. There's no good reason at all to smoke. And unfortunately, patients with pulmonary hypertension, we know that scleroderma affects a lot of young females with childbearing potential or in their childbearing years. But as I mentioned previously, pregnancy for these patients can be detrimental both for mom and for the developing baby. So in conclusion, pulmonary hypertension is common enough that we really need to be aware of this condition. I feel that most physicians that I work with, even physicians in family practice, internal medicine, this is becoming a very common topic, and we all are becoming more aware of this condition. We know that the symptoms that people experience could be from pulmonary hypertension, but there also are other reasons for patients to feel short of breath or fatigued. Patients should have screening echocardiogram at least once, but possibly as frequently as yearly. The right heart catheterization actually confirms the diagnosis. Treatment is available, and most patients on treatment feel better. And patients with pulmonary hypertension and connective tissue disease may need to make some lifestyle adjustments, but can still have a good quality of life. So what are your questions? Yes, ma'am.
I have a question first, then just a comment.
Sure.
Is echocardiogram and ultrasound the same thing?
Yes, they are. So the question is whether an ultrasound of the heart and an echocardiogram are the same thing, and they are. Yes, that is the same thing.
The other thing is just on a personal note. you were talking about the catheterizations, and I have to agree, they are not that bad. I mean, I've had 8 of them. I've had 5 stents and a right heart catheterization. The worst was the right heart catheterization.
Oh,
I
no.
don't ever do that again.
You just messed it up.
Yes.
Do you mean the left heart? Because the right is more common, isn't it?
No, it's the left.
She had-
That, with mine was the left.
So there's been some comments about the difference between a left heart catheterization and a right heart catheterization. To clarify that, or to try to explain, right heart catheterizations are done through the vein to measure the pressures in the right side of the heart. So right heart catheterizations are pressure monitoring types of tests. Left heart catheterizations are done through the arteries, and that's to actually look at the heart arteries. So look at the arteries that wrap around the outside of the heart to look for blockage or narrowing. If someone has had a stent put in or has had balloon angioplasty, then that was done via a left heart catheterization. Usually the right heart catheterizations are easier though.
No,
So-
the right heart was harder.
Did they do this, did they go through your neck?
I had 5 through my neck and 2 or 3 from my wrist.
So if we go through the wrist, that would be the left heart catheterization. That's done through the artery in the wrist. Yeah. Any other questions or, yes?
Since I've had scleroderma, like whenever I have like my blood pressure taken, I'm always on the low part of it. Is that common or not?
That is probably patient specific. The question was, a patient here mentioned that whenever she has her blood pressure taken, it's usually on the low side. So that is a patient specific sort of thing. So there are patients with scleroderma that have high blood pressure that might be on high blood pressure medication, but there may also be patients with lower blood pressures.
So if you had the pulmonary hypertension, you would tend to have higher blood pressure, correct?
Not necessarily. So whenever your blood pressure is measured, that is what we call systemic blood pressure. So that's actually making a blood pressure measurement of your blood pressure within the arteries, and that's a reflection of what's going on the left side of the heart. Pulmonary hypertension is more about the vein system and more about pressures on the right side of the heart. Does that help?
Yeah.
Yes, sir.
You mentioned 3 medications that were treating pulmonary hypertension. The first was sildenafil. The second you said was a medication that used to be injected and now it's in oral form. I'd be interested in what that was and how it differs from sildenafil.
So those medicines that used to be in the IV form that we now have an oral version for, those work on a different pathway than sildenafil. I will go back to that slide for clarification. So the question is just regarding the different classes of medicine. So if we're looking at this slide here, sildenafil and tadalafil, which are available in oral form, are considered phosphodiesterase type 5 inhibitors. The IV medication is called epoprostenol. That we give subcutaneously or IV. There is a newer version of that that is now available in pill form, and that is called prostacyclin. Those are prostacyclin derivatives, which are seen on the my far left side of the screen there. Does that help?
Well, how does that differ from the way sildenafil treats pulmonary hypertension?
Right. So sildenafil inhibits phosphodiesterase type 5 here, which then inhibits cyclic GMP. So this becomes kind of a biochemical discussion at this point, whereas the prostacyclin derivatives, they affect like a different pathway that we also think is affected in patients that have pulmonary hypertension. So it's kind of like if you, when we see patients that have high blood pressure, for instance, we have like 5 different classes of high blood pressure pills to use, or 5 different types of high blood pressure pills to use. So sildenafil is one type of pulmonary hypertension drug. Epoprostenol is another type of pulmonary hypertension drug. And there's different reasons to use different classes. Some have different side effects. You know, whenever I meet a new patient that has pulmonary hypertension, there's a lot of different things that go into why I would prescribe one class of medicine over another class of medicine. Does that help?
Yeah, I guess, but I'm still a little confused as to the differences in how sildenafil will benefit the patient as opposed to the latter medication you were talking about.
So all of the medications act to open the blood vessels in the lungs, which in turn helps to lower the pressures, and then that lower pressure then is transmitted back to the right side of the heart. So we want the pressures on the right side of the heart to be as low as possible. And by opening up or dilating the blood vessels in the lungs, that helps. So all of these medicines not only help dilate the blood vessels in the lungs, some of them also can help prevent the inflammation that's occurring at the actual blood vessel level, like in some of those earlier slides that I showed you. So they all of the medicines kind of do the same thing, they just do it by a different pathway. We are actually studying a lot of the medicines head to head right now to try to figure out if one medicine is more beneficial than another. And again, over time, as we have more research and these trials are published in our medical literature, that information will help guide us as we prescribe medicines. Right now, there's probably about 30 different medicines that are available to treat pulmonary hypertension. And again, a lot goes into why we would prescribe one medicine over another.
So when you say pathways would be the blood vessels, like how much it dilates, or?
Correct. So the
medications, the different medications would dilate the blood vessels differently, is what you're saying?
Pretty much, but all kind of to the same degree. So when I talk about a blood vessel dilating, there's going to be like 5, 6, 7 hormones that help that happen. Okay. And so each of these drugs are kind of targeting those different hormones, basically.
So what makes one drug different than the other, or like better than the other?
Well, that's what we don't know right now. We really don't know if some of the drugs are better or not. And so what we do is we take a group of patients and we prescribe, half of the patients we would prescribe sildenafil, and half of the patients we might prescribe another medicine. And then we follow those patients over a year or two to see who feels better, who ends up in the hospital less, who lives longer. And we're just now at the point where we're beginning a lot of those large trials to try to help us answer those questions.
Well, and I would think every patient would be different in the fact that everybody's blood vessels are different. So I guess how they react to the medication would be different as well?
Most definitely. Yeah, so sometimes I'll have patients that have, like, one of the common side effects from a lot of these medicines is nasal congestion. So there'll be some patients that say, no, I feel great, like my nose isn't stuffy at all. And then I have other patients who come in and say, you have to stop this medicine immediately. I am miserable. I cannot live another day like this. So that's a good, everybody responds to the medicines differently. Yeah. Yep. Go ahead, sir. Yes.
My pulmonologist mentioned a drug called Tyvaso.
Mm-hmm.
Are you familiar with that?
I am, yes.
As he explained it to me, as opposed to sildenafil, which opens up the blood vessels, this drug, how he explained it to me, or at least how I understood it, directs the blood to those areas of the lungs that are not scarred so that it becomes more efficient, that they're picking up oxygen from those areas where the lung is still working. Does that make sense? Did he explain that properly, or maybe I misunderstood? And the other, I guess the follow-up to my question is, why isn't that drug being used, or what would prevent you from prescribing that drug?
Sure. So the question is about a specific medication called Tyvaso. I myself would not describe Tyvaso as doing what your pulmonologist did. He may actually know a little bit more about Tyvaso than I do. I again see Tyvaso as a medicine that helps to dilate the blood vessels in the lungs, very similar to the way that sildenafil would. I myself am not aware that it directs blood flow to a better part of the lung than the other. That's not been my personal experience with that medication. The one downside to Tyvaso is that it's just difficult to use. It's an inhaled drug that has to be inhaled in a very specific way. Much like the inhalers that Dr. Amanula prescribes, if your patients don't use their inhalers or can't take the breath in the way they should, they're just not effective. And so there's a learning curve when it comes to Tyvaso. We have to do a lot of teaching with the patients to make sure that they're inhaling it correctly. And the way that we increase the dose of that is by the number of puffs. Usually it's given about every 8 hours or so. So you get to a point where the patient's tolerating 2 puffs every 8 hours. Okay, go to 3. Okay, go to 4. Go to 5. Go to 6. Well, then you get to this point where you as a patient are having to take 9 puffs of this medicine every 8 hours. And if you're already kind of feeling short of breath and fatigued, it might be really, taking 9 puffs of something might be like trying to blow up a balloon, which I'm even really not good at. So that's why I personally, and the other physician that I work with that does pulmonary hypertension in my practice, we have a couple of patients on Tyvaso, but it really wouldn't be our first line agent, if that makes sense. Yes, ma'am?
Is this more of a cardiologist's area or a pulmonologist for treatment?
Excellent question. So there's a lot of overlap. And actually, when I did my training at St. Vincent in Indianapolis, we actually had a combined cardiology and pulmonary clinic where every pulmonary hypertension patient that came in at the same time was seen by a cardiologist and a pulmonologist. And the reason why that overlap is so important is what Dr. Amanula was talking about earlier. On some of his slides, you could see that it might be pulmonary, it might be cardiac. And so it is very, very important that the cardiologists in the community have a good working relationship with the pulmonologist because there's a lot of overlap. I can't speak to the pulmonology training programs, but I know that there are specific training programs for cardiologists that are interested in pulmonary hypertension. They're usually 1 or 2 year training programs where as a cardiologist, you pretty much just immerse yourself in pulmonary hypertension for a year or 2. I would suspect that from pulmonary, there's also the same training opportunity.
I mean, yeah, there are many of the clinics that we had in Pittsburgh was also combined clinic. To answer the other question is, if you take the human airways and you top it off with fluid, it's only 150 cc's. That's all it takes to drown out those secretions. And when we start to give a lot of nebulizers, sometimes they'll actually become more short of breath because of that. That's when we transition patients to a non-nebulizer form of medications. So patients who typically would say, when I take a shower, I like to leave my shower door open. Those people who have difficulty with humidity, when you use these medications, what you see happening is you can really fill your lungs with water. When we do it very often, you can have a lot of liquid in the lungs. And so, so we keep that in mind also.
Thank you.
I have one more question.
Yes.
Your pictures of the lungs that were with the heart with the right side enlarged, and then after it got better, what got that result? Examples of what really can result in the enlargement going down.
Right. So that was medication. So that was so the question is what made the heart go back to normal on the echocardiogram slides that I had. So those were patients that were treated with approved medications for pulmonary hypertension. So 1 or 2 or even 3 of those 30 drugs that I was mentioning. The other very important thing, and I'm sure you would agree, if patients' oxygen levels are low, they need to be supplemented with oxygen. So time and time again, I see patients with elevated pressures on the right side of the heart's not working or squeezing well, and somebody tells me, well, yeah, the patient came into the hospital, they had a really bad pneumonia, their oxygen levels were critically low, and so sometimes just treating the patient with oxygen and getting the oxygen level up to normal helps lower the pressures, and then in turn the right side of the heart starts working better. So primarily oxygen if indicated, and then also pulmonary hypertension drugs. Thank you.